Intrinsic stains, on the other hand, are usually inside the tooth. They are usually from a pre-eruptive issue that the patient may have had. For example, fluorosis. You will commonly see fluorosis. Another one would be from things like tetracycline and antibiotics that maybe a patient took before they had a child, and it caused staining on the child's teeth. So when the permanent teeth come in, they will be stained kind of a grayish color stain. Intrinsic stain is inside the tooth and it has to be bleached out. You cannot polish off intrinsic stain. The 7 parts to your periodontal assessment include your probing depths, your clinical attachment levels, your gingival bleeding, suppuration, furcations, mobility, and tooth migration. All of those things or most of them, you currently do when you're in clinic. Think about all the things you're doing when you're data gathering. You're doing your perio charting, you're doing your recession, your Dentrix computer automatically calculates your clinical attachment levels, you're recording bleeding, any kind of pus or drainage that you might have. You should be recording furcations and mobility and any kind of migration of a tooth. I want to talk a little bit more about clinical attachment loss. So we had determined earlier that clinical attachment loss is the measurement of the pocket depth, which is the distance from the CEJ to the most apical extent of the epithelial attachment. And then we added to it any gingival recession. And that would be the distance from the CEJ to the gingival margin, which is pretty easy. If you look at the picture on the left, you can see that in that picture, there's a probing depth and there's also gingival recession. So you would add those two numbers together and that would tell you what your clinical attachment loss is. On the tricky side, the not so obvious, is gingival inflammation or changes in the gingival margin that go coronally instead of apically. When the gingival margin is coronal to the CEJ, the distance between the gingival margin and the CEJ is subtracted from the pocket depth. So when you have inflammation from gingivitis, let's say for example, if you're getting 4 millimeter pocket depths, if you look at where the junctional epithelium attaches to the tooth, it is still right in the place where it should be. There's been no migration of the junctional epithelium and no bone loss, hence the definition of gingivitis. But if you look at the picture on the right here on slide 28, you can see that you can have a pocket depth, but the gingival margin is up on the enamel surface higher because of gingival inflammation. So if you had a 4 millimeter pocket reading and you guesstimate 1 to 2 millimeters of that's inflammation, you would subtract that number away. So your actual clinical attachment loss would only be 2 millimeters, which is still in normal range. This is a picture of how Dentrix would record clinical attachment loss. So if you look at tooth number 2, you have a probing depth of 4 millimeters on the distal and on the mesial. The gingival margin, where it's in the little black square, is actual inflammation. When they're not in the little black square, like on tooth numbers 3, 5, 6, etc., that's gingival recession. So if you have gingival recession, like on tooth number 3, we're going to take that 4 millimeters and we're going to add 1 millimeter of recession, and we're going to come up with a clinical attachment level of 5. If you take tooth number 2, where you have 4 millimeter probing depth but 2 millimeters of inflammation, you're only going to have clinical attachment level of 2. Now when you look at that, you're going to be looking at that as possibly the patient having maybe some slight periodontitis, according to our new chart that we have in clinic. But you also have to take into consideration a normal sulcus depth is 0 to 3 millimeters. So if you're showing a clinical attachment level of 2, we're actually not showing any attachment loss. I will explain that more thoroughly once we get into this a little further. This slide describes the difference between primary occlusal trauma and secondary occlusal trauma. Primary occlusal trauma exists when you have a normal, healthy teeth and gums, and you have a parafunctional habit such as clenching or grinding your teeth. So you're putting excess occlusal forces causing pathologic mobility. Secondary occlusal trauma occurs when you already have a patient that has periodontal disease, and now they cannot withstand the normal occlusal forces.